Hello everyone, my name is Jim Gallagher. It's an honor to be with you. I'm the director of the William Randolph Hearst Burn Center in New York City and Weill Cornell Medicine. This is a picture of the Empire State Building, which is very close to our burn center. In this plenary, we're going to be discussing Burn Surgery 2, a look into the future 10 years. So I just want to take a moment to talk about the two things that I use in New York that will be discussed in this plenary. One is Nexobrid, and I was excited about Nexobrid when I got into burns. I've had the good fortune of being able to try the product. I'm still on the learning curve and very much look forward to its impact for burns in New York City. And the second, BTM, which we've been using for more than a year now, and slowly and carefully as we learn to use the product, we're becoming to rely on it more and more. And I look forward to hearing the discussions as part of this plenary. My look, though, into the future for 10 years is really more about burn care for all people. And what I mean by that is that for most of the world, there was no organized acute burn care, but rather burn surgery is contracture release, like this poor little girl has, had no surgery and no grafting, obviously, and therefore has a contracture. And I believe that everything is in place for this kind of thing to change. So, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And this is a quote of Dr. Martin Luther King Jr. from March 25th of 1966. And this is as true then as it is today. And my vision for the future, for 10, but more likely more than 100 years, is that the world burn community is leading the development of healthcare systems and improving outcomes. Okay? Taking a step back and just saying this is what the low-resource world looks like, both out in the hospital and out, and everyone asks, I do, what came first, the chicken or the egg? Is it the poverty or the underserving healthcare system lacking surgical care? Helping in the past was really only humanitarian service without really thinking that you could impact the whole system and make improvements. Until 2015, the Lancet Commission on Global Surgery, which is an international group of contributors from over 110 countries that provided an outline of the global situation of surgical care and direction for making and measuring progress. This is not a small statement, and there's a ton in here, but 3 key points I think are worth highlighting. First, 63% of the world's people lack access to safe and affordable surgical care. A nation investing in its healthcare system can expect a 10-fold increase in GDP for the investment. And to make positive change, it is the nation that must take the first steps. And they take that first step by making a national surgical, obstetric, and anesthetic plan. So if we take a look at a world map of poverty and the percent of people living on less than $2 a day, Africa, of course, we see here, as we know, has a tremendous amount of poverty. But it's this same group of people that if we look at the National Surgical, Obstetric, and Anesthetic Plan progress in the world, we can see they're responding by completing their plans, beginning them, and then publicly committing to creating NSOPS plans. So what we're seeing is that low-income nations recognize that the way out of poverty is to invest in their healthcare system and build surgical capacity. The problem is that Global Surgery 2030 from the Lancet Commission, there's no implementation plans on how exactly to move clinical care forward. This was recognized by the American Surgical Association, the United States' oldest surgical organization, which was formed in 1880, by this article which was put out, Global Surgery, Effective Involvement of U.S. Academic Surgery. And it's a report of a working group they formed on global surgery. One of their findings was that major actions to improve this situation, and by this situation what they mean is that 63% of the world lacks surgical care, major actions need to be taken by the surgical communities. I believe that burn care is the best surgical community to lead the way on improving healthcare systems. This may seem lofty, but building systems requires teams. We are defined by teams. Every day, all the care that we provide, we sit at a table together and we listen to one another. We value the members of team member contributions from all levels. This is unique in surgery and growing and recognized as an important component. In addition, we care for all ages, birth to death, all people. That is also unique to us versus other disciplines. We are interested in everything from triage, bringing people up through systems to the appropriate care, all the way through that we embrace and daily are working with palliative care given the injuries that we deal with. We deal with first aid, which we know will limit the number of patients that we have to do surgery on and even admit to the hospital. And we're always getting ready for that burn disaster, which is an important component of any healthcare system. And finally, prevention. Different than first aid, but critically important. And again, we know we're trying to actively, as burn care centers, reduce the number of patients we have. And we always want to be advancing our surgery to make better results, less painful, and less expensive. Burn center teams think holistically about the societal burn injury that they're treating, most often about the population that surrounds them. They think, let's make things better, less suffering, less disability and death, again, in a holistic way. And knowing that with increasing severity, we have small numbers of patients, and at the bottom, we have huge numbers of patients. How do we make this situation better? Well, we start with healthcare workers that can teach first aid and prevention, and a huge amount of nursing is needed right from the get-go and all the way through to the most complex cases. We need rehabilitation therapy, we need doctors, and then finally we need surgeons, which are really the team member that we need the fewest of. This ability to really think holistically helps us to process everything and figure out solutions, not only looking from top down, i.e. the surgeon perspective, and measuring progress in the number of new operations that are done, but rather bottom up, which is critically important when dealing with a problem of this magnitude, to look at prevention, first aid, building nursing to help really ease suffering, disability, and death in this problem. Next up is the NGOs, the non-governmental organizations, which are essential collaborators. These people, these groups are in the field in the low-income nations and are some of the most powerful NGOs in the world. And burn is a sub-discipline of plastic and reconstructive surgery. Operation Smile, Smile Train, Interplast, Second Chance, and many others have all been out there, long history, and very successful at doing what they do. However, they're aware of the change that's happening in global surgery, and they desire to be part of sustainable improvement and building surgical capacity. I want to point out Interburns specifically. Although an NGO, it's so unique it deserves separate discussion. It is the International Network for Training, Education, Research in Burns, and they do not focus on surgery, but rather creation of a comprehensive, integrated approach to capacity building, quality improvement, burn care, and prevention. On the left here, you can see that they've developed international standards for burn care, a participatory site evaluation tool by the team to figure out where they are and where they need to go that they can use to advocate for themselves in their system, and finally a comprehensive education portfolio including general education on burns, nursing, rehabilitation, and surgery. And all of this authored primarily by burn care professionals from low-income nations and middle-income nations, which is critically important in making its relevance clear. And finally, I want to share with you that Interplast, one of those plastic and reconstructive longtime members of the community there dealing with the surgical backlog, the untreated plastic and reconstructive cases around the world, has seen fit to fund Interburns' creation of this site evaluation tool, and make it entirely online. And so NGOs, if you're out in this world, know that they're competing for donor dollars, and to think that one NGO is supporting another is really notable. And finally, I offer this graph from Primary Surgery, Maurice King, non-trauma textbook, on creating the surgical machine. And what we see is a little surgeon there, ready to operate, but not doing surgery, rather embracing the leadership role. And so if you look at A, we see a surgeon who found a nearly perfect system, stepped in and out without needing to make a change. Dr. B finds a good system, and under his or her leadership it deteriorates and is worse than when they found it. And finally, C finds a dysfunctional system and improves it, and D, the surgeon is able to operate in chaos, makes no changes, and improves the system and leaves chaos. We in Burns embrace our role as a center in the community trying to improve things. It isn't much a stretch as a leader in Burns, once you get a look at what's going on in the world for acute burn care, to embrace this surgical machine concept on a global scale. Add to that the fact that the nations are doing what the Global Surgery 2030 is recommending, And they're taking the first steps by creating their NSOAPS plans. We in the burn community, with our teams, treating all patients, with our powerful NGOs and the Interburns model, I feel the time is right to act. We can bend burn care towards justice. Thank you.